And welcome to the Dr. Bob Show. Every adult after the age of 40 needs to have their eyes examined with their pupils dilated. That needs to be every 2 years. Why do they dilate the pupils? Do you know how the doctor does that? Does it hurt? How long does it last? Is it dangerous? My guest is Dr. Darin Smith. Dr. Smith is a board-certified eye specialist, ophthalmologist, and he'll be answering our questions. He could be the first one to find high blood pressure, hypertension, diabetes, elevated blood sugar, glaucoma, age-related macular degeneration, and he finds it before maybe the primary care doctor could. Illnesses that could save your life and save my life. I'm as interested in this show as you are. You'll want to stay tuned. We're talking with Dr. Darin Smith, board-certified ophthalmologist, that's MD and eye doctor, and we're talking about dilated eyes. Darin, welcome to the Dr. Bob Show.
Hey, thank you for having me, Dr. Bob.
Tell me, what is a dilated pupil? What does that mean?
Okay, well, so the pupil is the dark center, you know.
Yeah.
And so what that is actually made of is the iris is the colored part of your eye. And so when we dilate the pupil, it's a little medicine we put in there. It's just a drop. It burns maybe just for a moment when it goes in, but no big deal. But over the course of maybe 10 or 15 minutes, it will make that iris move out of the way.
So it pulls it out of the way and makes, therefore, the pupil
big.
Real big.
Yes.
And so how does that help you? If you didn't have it, you'd be looking through a skinny hole. Now you're looking through a big hole?
Exactly. So it opens basically a window so we could look into the back of the eye and evaluate the eye for cataracts. We can look at the optic nerve in the back of the eye, look at the retina.
You can see the nerve that goes to, it's called the optic nerve?
Yes, sir.
Is that the nerve that really carries, I can see?
Yes, sir, it sure does.
So let's talk about, what are those drops made of? How do you put them in? And you say it takes 10 minutes and it dilates up and then you're ready to go.
Yes, and so basically, there's something called atropine, which was used back in the Middle Ages, actually, to dilate pupils. But atropine could actually cause a lot of problems with the heart and a lot of other issues. And so these are all derivatives of atropine, and that's just an eye drop. It comes in a bottle, and you put a drop in there, burns for a minute. The thing that people don't like about the dilation is not only does it make the pupil big, and so when you go outside, your eyes can be very light sensitive, but it also makes, for some people, the vision a little bit more blurry, especially for the up close.
How long
reading.
does that last?
About 4 hours, give or take. People with
hours.
a real lightly colored eye, blue eye, might take a little bit longer for it to come down, and darker colored iris sometimes is a little harder to dilate.
How often should people after age 40, how often should they have their eyes dilated?
Yeah, I mean, I think every couple of years, you know, unless there's something else going on, but just as a general routine, I think that's pretty reasonable.
So what are some illnesses that you can pick up before the doctor does at his examining table?
So as far as, you know, things that aren't just for the eye, you mentioned in the intro diabetes. That would be probably one of the most common.
We'll come back to that, diabetes.
Yes. High blood pressure?
So you can find diabetes and high blood pressure by looking at the eye and saying, you know, you got hypertensive changes, high blood pressure changes. Go see your doctor.
Absolutely, we can.
What other, those two things?
So sometimes less common, you can actually see things that might make you think that someone might have some sleep apnea. That would go along with some optic nerve changes.
Wow.
So there's a number of things. I actually just sent someone to the hospital the other day who came in complaining of having hard time seeing in the left eye. And after examining them, I actually sent them to the ER emergently because they were having a stroke.
So you could diagnose that by a dilated pupil before anybody else knew they were having a stroke?
Yes, she had no idea she was having a stroke. And I sent her out of my thing and said, you need to go to the hospital immediately.
Can you detect cataracts?
So cataracts are probably one of the most common things we see. And what a cataract is, that's just where the natural lens in the eye gets cloudy.
So normally you would see right through it, but it's cloudy when you look at this big dilated pupil.
Right.
How about macular age-related? I don't like
Yes.
that. I think can you see that?
Absolutely. So macular degeneration is just, it's usually age-related. The macula is like the bullseye, the center part of the retina. And so just with age, the macula can become weak and degenerate. So early stages, we see just little pigmentary changes there. There's two forms of macular degeneration. There's what's called dry and wet, and we can maybe get into that more later. But basically, age-related degeneration on the retina. But we see that quite often too.
So I want to start off with diabetes. I want you to prove to me what you can see in diabetes that I couldn't see when I normally examine the patient.
Sure.
So what do you see in the eye that makes you think diabetes?
Okay, so for diabetes, and we were asking about how often to be seen, diabetics need to be seen every year with a dilated exam.
For sure.
If they have nothing else going on. So with diabetes, will cause blurry vision, loss of vision in a few different ways. The early stages, we'll see tiny, like little dots of blood on the retina, or sometimes little leaky blood vessels that will cause some protein buildup in the retina.
The back of the eye is the retina.
Yes.
You can see that real easy, and you can see little spots that are blood spots.
Little splotches of blood that
Where
you
are they
can't
coming
see.
from?
Well, what happens is with the diabetes, diabetes is related to high blood sugar, but what actually happens is that causes problems with the small little capillaries, the small little blood vessels.
The little smallest, but and they'll rupture and they leave a little spot in the eye, and you can say it and say, the more I look, and there's some other changes of diabetes other than the micro hemorrhages, the small ones. What else do you see?
So when diabetes gets very bad, new blood vessels will actually start to grow. And the reason that happens is because the retina gets what's called ischemic. It starts to lose blood flow. And so the eye says, hey, we're dying over here, we need more blood vessels, and so we'll make new blood vessels. The problem is those new blood vessels will break and bleed and scar and can cause really serious problems.
So you can see larger blood vessels that bleed into the back of the eye. Do you ever see anything called an exudate? What is that, and what happens in the eye?
So an exudate is the protein buildup that I was mentioning. So that would be the medical term for a little collection of protein in the retina.
What's it look like? If the retina is this big, how big is exudate?
A dot.
A dot.
I mean, and then if there's a lot of it, there might be multiple dots, but it's like a little yellowish white dot in the retina.
So when you see that, do you say, we're going to have to figure out a way to help this person's eyes? What can you do to get rid of those, or you just get the blood? You see a diabetic doctor specialist
Absolutely.
who gets the blood sugar, A1C properly.
That's the most important thing. But as all this is happening, sometimes there'll be some swelling of the retina. And if you actually start to get some swelling of the retina, what we call edema, if you get edema or swelling of the retina, that can actually bring the vision down. And there are some different things that can be done for that. But anytime a diabetic, we start to have some early signs. So let's say someone comes in and has early signs of diabetes, but really no edema, none of those new blood vessels. We'll start to see those folks about every 6 months, just to make sure that things aren't getting worse, and make sure that they're following up with their primary care doctor or their diabetes doctor to make sure that the blood sugars are being well controlled.
If you get edema, if you get swelling behind the retina, can it be pushed out of the way, detached?
Well, so depending on what's going on, the treatments for that have gotten different over the years. When I first started training back in the mid-90s, the only thing that could be done for that were laser treatments. Nowadays, there's actually injections in the eye, and a lot of people might have heard of people getting injections for macular degeneration, but they also get a lot of injections for diabetes also.
How do you inject the eye? Does it hurt?
It doesn't hurt as nearly as bad as one would think.
And that's what we're going to be talking about when we come back. If they stick a needle in your eye, why doesn't that hurt? It really doesn't. It just absolutely blows my mind. You'll want to stay tuned. We're talking with Dr. Darin Smith, board certified ophthalmologist, eye doctor with an MD degree. Well, where did you get your MD degree?
I went to Duke University.
Went to Duke. That's a pretty high class sort of place, isn't it?
I was very fortunate.
They have a good eye program.
Oh, it's fantastic.
Yeah, and so you've been a fantastic doctor for Knoxville to have. We were talking about how you stick the eye with a needle. What do you do?
So basically, you just there's a numbing drop you put in there, and the needle is very small. And again, the idea of that for people sounds just horrendous.
Yeah.
But the actuality of it is not too bad. And the reason people get the shots in the eye are really saving vision. So if your choices are go blind or get an injection in your eye,
I pick an injection.
You go with injection.
You know, I see people come to my office and they say their treatment has been with injections into the eye where they stick a needle in and they inject the proper medications. And I say, doesn't it hurt? And they say, no, doesn't hurt at all. They didn't it, and you don't know anything's going on. That's fantastic, and that's modern medicine, and that's what you all practice. Now, let's go to high blood pressure, hypertension. Can you find hypertension with a dilated eye that you're looking at?
Absolutely, and without a dilated exam, we wouldn't really be able to see it. So early signs of high blood pressure that actually haven't caused problems in the eye would be sometimes there's little tiny arteries and there's little veins, and sometimes the little arteries will get thin.
You can see an artery in a vein.
Oh, we see it every time when we're looking back there in the dilated eye exam. I see the nerve. When I say I see the retina, of course you see all the blood vessels.
Oh my gosh.
On the retina also.
To me, when I was looking at an eye in medical school and in training, I thought it was the most magnificent thing I had ever seen. So you can see the blood vessels, and what do they do that tips you off? They've got high blood pressure.
Sometimes if they're real narrow, sometimes as the artery will cross over a vein, sometimes if that artery will kind of press on it and make a little indentation in the vein, and then we call it AV nicking, arterial venous nicking. And there are other things. Sometimes there'll be bleeding similar to the diabetes that we talked about. So sometimes we'll see little, if I see a little splotches of blood and someone doesn't have a history of diabetes or high blood pressure, I said, well, you need to go get checked for both.
Do the nurses measure somebody's blood pressure in an eye doctor's office?
We will occasionally. If I have a reason to suspect that the blood pressure is elevated, we certainly have the ability to do that. We don't check blood pressure on everybody, but we certainly have the ability to.
So if you see signs when you're looking at the eye of high blood pressure, you say, have you ever had elevated blood pressure? You go see your doctor about it and tell him, I can see some eye changes of that, and we need to get to work right now because you're a candidate for having a stroke. Let's jump off hypertension. So you can figure out diabetes, you can figure out high blood pressure. Tell me about cataracts. When you dilate an eye, does it make cataract diagnosis easier?
Makes it much easier. So without the dilation, you could maybe see if it's a bad cataract, you could see it a little bit. But once we get that pupil out of the iris out of the way, so big pupil, we can really see that, the whole lens. And that's critical. Like I mentioned, what a cataract is just where the natural lens gets cloudy. And so
what makes them cloudy?
So it's just age. As we age, the protein composition of the lens changes with age. And if you think of it like this, the lens basically continues to grow throughout life, but it can't grow bigger. So as it grows, it just grows more dense. And as it grows more dense, it becomes cloudy.
And when it gets cloudy, what happens to the eyesight?
So it goes down. It can be blurry. One very common symptom would be glare, trouble driving at night.
Halo vision at nighttime?
Halos, sometimes trouble reading like the little ticker on the bottom of your television for sports or news or weather, that sort of thing. So those are some of the very, very common kind of symptoms.
So there are some symptoms that hey, something's going on with my vision. What is it? And you can say, well, you're beginning to have cataracts. Does that mean you have to do surgery right then?
No, it does not.
What do you do then?
So if it's not really bothering you, and if it's mild, you just maybe get some new glasses and go on with life.
How often do you come back to have it checked again?
Well, once a year.
Once a year.
Yeah, once you get to be in the 60s, it usually try to go up to about once a year as far as a visit. And most folks at that point are starting to get some cataracts. And the thing is, cataracts grow very slowly, usually. Not always, but usually. And so a lot of times those changes are subtle. And so people don't realize how bad things have gotten until it's gotten really bad. And so, in fact, I was doing surgery earlier today on the second eye of a gentleman, and I hear this a lot. He was shocked. I mean, just absolutely shocked at how much better his first eye was. He had no idea how bad it was until he had it fixed.
And people say I was blind, but now I see, which is sort of biblical words. But they say I had no idea what colors were like, what leaves looked like, what birds flying really looked like, because everything was so cloudy. So when you're doing cataract surgery, what do you do?
So what we're doing, it's a very small incision. Cataract surgery only takes about 10 minutes.
Wow. So it's a lens that you got to do something with. What do you do with it?
Yeah. So we actually remove the natural lens, which has gotten cloudy, right? So out with the old, and then the lens implant goes back in. The incision we make is only about 2.4 millimeters. I mean, it's
a little bitty
very
thing.
tiny. And so the lens implant that we put in is made of a foldable acrylic. So we fold up that lens, slip it through that 2.4 millimeter incision, and then unfold it.
It comes out
inside the eye.
So are there different types of lenses that you have learned that you like better, you personally like better than others?
Yes, sir. So all lens implants come in different powers. And so I'm always the one that will choose the power. But patients get to choose what type of lens. And so what most people get are what's considered a standard lens. Generally speaking, that's what's covered by insurance. As a rule of thumb, a standard lens would help with distance vision, but wouldn't do anything for up close. And it doesn't do anything for what's called astigmatism, if someone has astigmatism. So
you may still need glasses later on to be able to read,
yes,
but you can see far away. Is that correct?
So standard lens, I would expect, depending on the amount of astigmatism, either just some reading glasses or maybe a light pair of bifocals.
Okay. So it's not a cure-all. Are there some lenses that are a cure-all?
Yeah, there are. So there's lens implants that help treat the astigmatism. And so with those lens implants, that would help someone get out of their distance glasses, even more so if they had a lot of astigmatism. And then there's what's called a multifocal lens that can give distance and up close. So even if you do the toric lens, that's just for distance. So the multifocal lenses can give the distance and the up close vision and treats astigmatism.
So I would think I would want the multifocal, but let me look out there and look up here. Why not?
So
cost?
They're costly. Depending on the doctor,
some doctors like to use it, some don't.
Yes, there are some potential side effects with some halos around lights at night. That's not usually debilitating, but it bothers some people, and some people just aren't good candidates. We mentioned macular degeneration. Well, people with macular degeneration are not good candidates for multifocal lenses. So that precludes some people from even being a good candidate, so they can't get that sort of thing.
I'd still say, hey, isn't there any way I can get that multifocal? But the standard ones, it's amazing what you all can do when suddenly somebody says, I can't believe what I've been missing all of this time. Other eye problems that we can work on?
Well, gosh, yes. I mean, so, we mentioned...
How about glaucoma?
We mentioned glaucoma. That's exactly where I was going.
And that's what we're going to be talking about when we come back. What is glaucoma, and why is examining the eye with a dilated pupil help the doctor diagnose one of the hidden causes of impending blindness? A lot of information. We're talking with Dr. Darin Smith, board-certified ophthalmologist, eye specialist, and I've been amazed because with a dilated pupil, that's what we've been talking about, You can diagnose diabetes early. You can diagnose high blood pressure earlier. You can diagnose cataracts much, much better. And now we're going to get into glaucoma. So what is glaucoma?
So glaucoma is basically where high pressure in the eye
Inside the eye.
Inside the eye. So not blood pressure, but pressure inside the eye can damage the nerve kind of slowly and progressively over time.
So the pressure of that fluid pushes against the eye nerve, and what do you see?
So basically, what we're looking at with the dilated pupil is when we're looking at the optic nerve, there's something called the cup to disc ratio. And so
cup to disc. Now the cup would be where that pressure is pushing back and gives a cup in there.
So if you think of the optic nerve, it kind of the analogy would be that of a donut. And so the disc would be the whole the diameter of the donut, and the cup would be like the donut hole.
I've got you. So is that easy to see?
It's very easy to see. And so when we're looking at that, if that middle cup is enlarged compared to the whole nerve, that's just a risk factor for glaucoma.
So then do you go look and check and see what the pressures were?
Yes.
Now back when I was in medical school, back in the dark ages, we just blew a little air burst at the eye and it would give you a pressure, and we said, yes, you've got it, or you don't have it.
Yes. So our understanding of glaucoma has really increased over the last, 20, 25 years. And so basically, you're right though, a long time ago, it was just thought that it was only about pressure and that was it.
Yeah.
And so now we understand there's a lot more to do with just the anatomy of the eye and the blood flow to the optic nerve. And so one thing I think that everybody needs to keep in mind is just getting a pressure check isn't good enough.
Wow, and all this time, I would have said, be sure and get your pressure checked. So you've got to have your pupil dilated. An eye doctor has to look at the eye where he can see the optic cup.
Yes.
How does the nerve get into the eye? Where does it come from, the brain, or where does it come from?
It's an extension from the brain, basically.
And so with glaucoma, that donut, the hole gets bigger in there where the hole in the donut is, and the cup gets deeper.
Well, what's actually happening, the reason that cup gets bigger is that the pressure or there's different theories, but one is about direct pressure, one is a theory about that the pressure actually decreases blood flow to the nerve. So there's different thoughts about exactly what's going on, but nerve tissue is dying. So you lose the thickness of the nerve layer, which we can measure now, and then as the nerve tissue dies, that cup gets larger. Because what that cup is, that's where all the nerve fibers from the retina are going back to the brain for visual processing. And so as you lose the nerve tissue, there's not as much nerve going back there, so that cup gets bigger.
So there are specialists now that are just glaucoma specialists.
Yes.
When you see glaucoma, is that the time that, hey, we've got a physician who does just cataracts, because they can be very tricky and very dangerous, and it's changed a lot. I want you to see Dr. Cataract Doctor.
Right.
Or Dr. Glaucoma Doctor. So how do they treat them?
So I would venture to guess that most ophthalmologists treat a lot of glaucoma. So I have a lot of patients who are treated with glaucoma, even though it's not all about pressure anymore. And I think I was telling you before, off camera, at least half probably of the patients that I've diagnosed with glaucoma don't have really high pressure. So the idea that it always is high pressure
is wrong.
It is wrong.
Or it could be wrong.
It could be wrong, but it's still, but that said, every one of our treatments for glaucoma are all aimed at lowering pressure. And that could be with drops, with laser, or with surgery.
So you've got the mechanism to take care of the glaucoma and fix the eye and keep the blindness from occurring. Actually, you all are amazing. The fact that you can see diabetes and hypertension and cataracts just by dilating the eye. How often do you need to get that eye dilated if you're doing okay?
I mean, I think if you're doing okay and kind of young, every couple of years is fine. As you get older, in your 60s, and up, I'd probably about once a year.
Darin Smith, I love having you on the Dr. Bob Show because you're always full of information that helps us understand the eye. Now remember, it's time that you and I be thinking about those 4 things that we like to talk about every show. Number 1 is exercise. With exercise, it'll make you healthy, you'll reduce stress, you'll feel better, you'll get a runner's high, you'll be happier, your blood pressure will go down, and you won't have the eye changes on your eye. Be sure you're eating properly, eat good food, eat less food, more vegetables, more lettuce, less fried, fatty food. Be sure you're getting your 7.5 hours sleep. It's so important. And we're learning in medicine that sleep may be one of the most important things that you can pay attention to. So pay attention if you're sleeping soundly. If you're not, see a sleep specialist. And most of all, what is it we like in the Dr. Bob Show? You know, it's that laughter in your life. Find somebody you love, tell funny stories, laugh a lot, enjoy yourself. The more you laugh, the people around you will be happier and you'll be healthier.